women whose dilators fell out, had bleeding, and then the dilators fell out. The reason for dilators, the reason I put this slide up is that if you ever put the dilators in, you should put them in so that the tip of the dilator rod goes in through the internal cervix. Otherwise, the effects will not make any difference to the cervical widening. So the study that we conclude with this observational study is that you can have a very high cervical widening effect with a vaginal delivery rate that can be as high as 83%. But I think that depends on individual hospitals' management policy. It's safe. You don't have that hyperstimulation risk. You don't have the fetal abnormality risks. There's no infection-related risks. The patients are satisfied because only a small number of patients have mild contractions. And even that is only with 3% of women actually having any discomfort that they need analgesia for. And the groups that we want to look at it further is that whether previous zone sections and the high-risk groups, and again, the outpatient effects when you're using something like a hygroscopic dilator might be the future. So our conclusion from that study is that synthetic dilators are possibly to achieve in a large group of patients around the world, showing that there's high delivery routes, vaginal delivery methods. 12 hours, don't use it for longer than 12 hours, 4 dilators, no safety concerns, and potentially useful in VBAC and other high-risk groups and outpatient use. So we are actually currently doing now the SOLVE study, which has actually started to recruit using synthetic dilators versus PGE1, so your dinoprostal, the slow release 10 milligram dinoprostal. So this is a randomized control trial that we are in induction of labour in our units and multi-center to identify whether is Dilapan comparatively with dinoprostal PGE2 going to be useful. But there are other studies that have just been done. There's a Dilafold, Dilapan S versus Foley, again a randomized controlled trial that has just finished recruiting in Galveston in Texas. So that will be an interesting. I suspect it will show no difference between the two. It's a non-inferiority trial. And then there is in Warwick, my local area, there's another study about what after PROPES. And then there's the Galveston group are also looking at Dilapan S in the outpatient regime, which I think is really quite exciting, because I think that's what we should be looking at to try and reduce cost overall in healthcare services. My last slide is really about, should we have vaginal delivery within 24 hours as a parameter? Should we really look at this as our main method to identify? Once you start the induction process, should we aim for a delivery within 24 hours? My view is fast and furious a better way, or the slow and steady? And I think with these trials that are coming out, we will try and show, we know that with the Foley catheter, the slow and steady approach is no worse, but we need to show that the same with other methods as well. Thank you very much.
Thank you, Janesh. A lot of exciting new data and a lot of data to wait for, whether they come from America or the trial that we're running now.
Yeah.
And I'm all aware that we're going to progressively change our way of working everywhere. And a lot of these people are coming back with your slides on their phone. Thank you. We don't have time for questions, but there are no questions on the keynotes, and that allows us to move on forward.